Alright.
Alright, EGM Conference from now on. Today's busy, so if you have any opinion, please feel free to share your opinion.
민정? Yes, speak up, please. A little bit. 목소리. 그런 거 같은데? 커넥션이 별론 거 같아.
마이크로
됐다.
황준균 혹시 잘 들으시나요?
황준수한테 그걸 거기다.
잘 들려요.
Yeah, good morning. Good morning. Good morning.
So this is the white QRS tachycardia, and there is the VA dissociation, and the morphology criteria that very fit in, but I think it is a bit more peripherally briefly.
Where is VA dissociation?
On the last, is it the reach to
Rhythm strip, yeah. And which beat?
maybe the middle part is the fusion bit, and maybe slow P wave proceeding near the QRS complex is not regular, so I think it's the VA dissociations, and the late bit was the paced rhythm. So
세용.
It's a lot of fusion beat,
Oh,
fusion and capture beats.
can go. Okay. Fusion and capture beat. And that's it.
So this is a 12 ECG showing regular rhythm with multiple QRS morphologies. Likely a VT with fusion and capture happening. So I can see a capture beat in V2, the fourth beat, and so likely a VT. Now, feeder axis PF is positive. 1 and AVL is negative, so it's likely coming from left side, left basal.
And it's right bundle branch block panel or left bundle branch block.
It's right bundle, but there are fusion in, so it's changing.
No, I think on the V1 we can see the one
Right bundle.
right bundle. So the location of the VT. Can you predict the location?
Yeah. So if V1 and V2 is V2, V3 is positive, then V4 becomes negative, V5, V6. So it's probably because V5, V6 is S and likely subvalvular from the left side.
But I think that is paced rhythm. you mentioned.
Yes.
No.
They are facing spikes.
V5 and V6.
Hmm.
But last 2 bit might be the tachycardia, right?
Right. So it's mainly positive concordance. So coming from
Mhm.
left
Left side.
left base, mitral annular,
Left side,
left
basal,
side, basal,
and
one even negative mitral
anterior.
lateral,
yeah, anterolateral. Okay. Theo, do you agree?
Yeah, I almost agree. And I also can see the V4 and V5, V6. There is little pacing blip in there. So maybe those 3 bits are the pacing rhythm. Not likely to the CSP could be ventricular pacing. And for other bit, it is regular and white curse tachycardia. And when we see the AVR lead, the initial Q width to the Q is more than about 80 or 10 or 100 milliseconds. So it looks like VT. Also, the termination is faster than the initiation in the AVR lead. So this science can say that this is VT. And about the location, as you mentioned, the 2-3 AVF and the V1 positive. So and the V3-4. I think the second bit of the V3 is the VT rhythm, and others can be pacing rhythm. So V3 and 4 is positive. So I almost agree with the VT origin, and that's my opinion.
Thank you.
Thank you for your opinion. We talk more. Yes.
Before you say, can you go back there? Hello.
Hi.
Good
Yep.
morning. Good morning. So why the rhythm is irregular? The first question. Second, how many QRS morphology do you see? That's the next question. You already figured a couple of bits are paced. So patient has a device. In that setting, if this was VT, why so irregular? Can you tell me what the mechanism of VT is then? Only time patient ventricular rate is regular when it's paced. Otherwise, RR interval vary too much. Is this typically what you see in the related monomorphic VT or not? What is the characteristic of re-entrant VT? They're very regular, right? This is not regular rhythm. So the next question we have to address, what is the atrium doing here? Have any idea? If this is a fifth, flutter, or sinus rhythm, what is this? I think we need to discuss this systematically. These are quite complex EKG. So anybody thought the possibility this could be aberrancy? How about atrial fibrillation flutter with the aberrancy? Can you exclude that with the intermittent fusion with the pace rhythm?
Flutter is possible.
Can explain.
Flutter with 2:1 conduction is possible.
So if you look at the V1, right bundle morphology, it's a typical atypical aberrancy pattern.
Atypical, one of R.
Well, you have a small notching in upstroke, right? Second rabbit ear is a taller. So what does that mean? V2 has a taller R and smaller in a second notch. But the V1, you cannot exclude the possibility this could be a aberrancy, maybe. And second bit is the narrowest guy is, because you can see the second bit in V2 is a precordial lead. At V1, V2, you have a very narrow complex. So I see 4 different type of QRS here. And I think we better explain this. Think about it, make a differential diagnosis before you guys move. Okay? So you need to question why you don't see clear-cut P wave. In lead 1, what is that small blipping in the front of a QRS? Very sharp blipping. That's what you think a complex V or A? Lead 1, you can see very nice sharp potential. And the patient heart rate is what? Is fast and irregular. QRS duration fluctuate according to the rate. Many things here against the VT. Could be atrial flutter, fibrillation with a varying conduction in view of pacemaker sensing some of this wave and pacing that give you upper rate behavior of the device, which is what you see in V4, V5 is, okay? So this EKG is meant to make a differential diagnosis. I understand you try to comment, make a diagnosis. We discussed before. Please make a differential diagnosis. Open up what's the possibility to get all can be. That's how we exercise your brain. Okay? All right, let's go. Next
I
slide.
think we can see the P wave at the last 6 beats. There's a P wave and the paced QRS. There are 3 beats, right?
Yes.
Can you follow the mouse?
You
need to find the rhythm trick. Last yeah. Okay, so I think that there's P wave followed by paced QRS. So not the ECG interpretation, but in the clinical sense, V pacing in this tachycardia status, this patient may not have a pacemaker, but probably the high energy device, ICD or CRT, and also the wide QRS in between the wide QRS rhythm. There's different QRS morphology intermittently. So first 8 beats, yeah, rhythm strict, yeah. And it occurs again, same rhythm in the middle of ECG, another one, and change to be narrow QRS. Go right side. More, yeah. And at the time you start the pace, right? Yeah, in the even V3, you can see the pace, the B rhythm. So I think that this patient has, I don't know, it is that atrial tachycardia or sinus tachycardia, whatever, but the rhythm looks like the piece sensed QRS pacing. And regarding the wide QRS rhythm at the left side rhythm, I prefer the VT because the different QRS morphologies looks like a capture bit in between. So not only the ECG interpretation, because the fellows already read, point out the important points, but I prefer this patient has, I don't know if it's sinus tachycardia or atrial tachycardia. Atrial rhythm is fast, but the ventricle also has a wide QRS complex ventricular tachycardia. And the location is likely to the basal anteroseptum, as Washington mentioned. That's my thoughts.
So what is Dr. Bach, what is the mechanism of QRS getting narrower? If this is a VT, okay, then what's the mechanism of narrowing complex? I think that's important to teach the fellows.
Yeah, I think that one possibility is VT terminates transiently, or sinus conducted P wave QRS is mixed and generating the fusion or capture beats. Because the later part of rhythm strip the P conducted QRS, not the pace rhythm. In the middle of a part, there's a little different shape of QRS morphology. So I guess if the sinus rhythm or atrial tachycardia take over the narrow QRS rhythm in between the wider QRS, that's one of possibility. But it's one of possibility. So we need to exclude the potential aberrancy.
Yeah, let me explain this. If this patient had right bundle branch tract aberrancy, if you pace same time, you fusion, what would it be? You pace a right ventricle would be what? Left bundle. If the timing is correct, fuse it together, give you narrow complex. Okay?
Yeah, that is so-called balance bundle branch.
That's correct. That is present in the last rhythm streak called the third bit, last one from the last three. Yeah, that one. That's a fusion between native conducted bit and paced bit because your P wave precedes almost exact same timing as the first three complex. So this is evidence that could suggest a BT, but you cannot rule that out possibility of right bundle aberrancy with the pacing came on time, merged, became fusion. And then probably happened also on the very narrow complex and the V1 second complex. If you go to the V1 second complex, they're extremely narrow. Yeah, that may be the narrow native complex. So yeah, that's the one.
The classical thing is if you have a wide complex tachycardia and you get in between narrow complex QRS, the diagnosis is always VT.
That's a point, and not always BT. If you have a device that
but
is.
Here the situation is slightly different because there's a device and there's a spacing taking place. There can be a fusion between the paced and the ventricular beat and make it narrow. But
That's
otherwise,
correct.
if there is no device and you have a wide QRS tachycardia, and in between it becomes narrow, there cannot be any mechanism except a beat.
That's a well-known. We taught to many people, many of our mentors taught many years ago. Okay, your comment is welcome. Okay, let's go. Next slide. Okay.
Some more information about this patient. This is a 62-year-old male who presented to our emergency department after experiencing shock events from his implanted therapy device. Regarding his medical history, he had ischemic cardiomyopathy. He initially underwent ICP before, which was upgraded after 4 years later to CRTD in our hospital. And he also has a history of recurrent monomorphic ventricular tachycardia, for which he underwent RFCA and redo RFCA. For his heart failure, he had been on guideline directed medical therapy. His chest X-ray is like this in March. So we interrogated the CRT device. The CRT interrogation revealed a recorded VT event, and shock was appropriately delivered according to the program setting. So, and the problem was even after arrival in the emergency department, sustained VT persisted within the VT monitoring zone of the CRT device. Therefore, the patient was submitted for monitoring of VT storm and further evaluation. Due to the patient's persistent VT episodes, RFCA was planned. After the admission, he took a heart CT. The conclusion is like this, and also he He underwent an MR. MR had shown many, MR also showed results. So he's discharged now, so he's going to readmission later for the VTRC. And I think for the long-term plan, we should consider heart transplantation. Thank you for your attention.
I have a question for you. Why this patient has so fast ATR rate and surface ECG and the intracardiac electron both? Is this atrial tachycardia or?
I think the interrogation shows VT.
If that EKG that she's shown that indeed that sharp spike is a potential intubated ECG, go back to the EKG, okay? First ECG. Yeah, right there. This P wave, it looks like a sinus. It's assuming that the lead 2 is upright, right? You can see P wave on an in and out of a QRS complex. Yeah, that's sharp front. Yeah, that guy, positive. Lead 3 may be biphasic. Lead 1 is also notched. AVL is also biphasic. What do you think? This is a normal exercise rhythm or not?
Maybe not.
Yes, it's probably ectopic
Can I
tachycardia.
see the next ECG? Okay.
Yeah, this is a sign of rhythm. This patient. See, lead 1 is a completely different. Lead 3.
Still, it is pretty fast, right?
Yeah, but not that fast as the first one. So might be going ectopic tachycardia simultaneously, I think.
Does a patient is taking beta blocker with enough dose?
Oh God. Bisoprolol.
It's a problem. 5 milligram.
I
So
have a last question for you. Can you go back to that sinus rhythm ECG? Sinus, yeah, device. Is device working well, guys? What's happening with this device? It's just fair curiosity. What do you think? This is a CRTD by BICD.
Since V-base, it's predominantly LV based because V1 is positive.
LB paste or LB timing is early. Be careful what you say.
Maybe LV timing, LV offset is early.
So where's the second spike? Pacing. Precordial lead. You can see second spike. See, the first one is the LV is first. RB pacing is where? Can you see? And then look at the V4. You see that notching, blipping. Yeah, next one. Downstroke. Next one. Yeah, that is RB pacing spike. So we need to interrogate these spikes again. Maybe you need to adjust it. Could be even narrower than this if depending how your timing is. So please check the timing of a LV RB pacing in this patient. Okay. It is going to be important to adjust for this man. May not be appropriate. Okay. Sometimes fall even after QRS, I can see in B5.
And also, I think that we need to review the medications because even though it is sinus rhythm, heart rate is quite fast.
Right.
So maybe we need to increase the dosage of beta blocker or use another drug. Or if this patient is hemodynamically distressed status, probably could increase sinus heart rate. So of course, the VT ablation is appropriate indication, but he didn't take antiarrhythmic drug so far, right?
No.
Am I right?
Yes.
So it is Vanish 2 indication. Which you can try BT ablation, but we need to take care of the general condition and the general medication of heart failure for heart failure. And the atrial fibrillation also can precipitate the BT in this kind of sick patient.
How was he medically managed? What antiarrhythmics were given for VT?
So who is the charge faculty of this patient?
Speaking more loudly.
응? 뭐라고 그런 거야?
Professor.
안 들려 지금 뭐라 그런지 자네가 한 얘기가.
범죄 선생님이라고요.
께서 지난주
I mean, was amiodarone used or what to control the VT? What was the intent?
So, Dr. Ba, can you hear me?
네.
Okay, so
Yes.
this patient has a diagnosis of ischemic cardiomyopathy VT, correct? Am I wrong or yes?
Right.
But we need to check the MRI
Oh.
because some of ischemic VT patient has combined dilated cardiomyopathy, but he has multiple coronary artery disease, maybe ischemic
Right.
is major
Yeah, I
cause.
think question is going to be if the given location of ventricular tachycardia 12 ECG. I'm not sure that's all clinical VT. If it is ischemic, as you know, giving an antiarrhythmic drug, sometimes amiodarone, ablation outcomes not very good. That may be because you're hiding potential subendocardial scar circuit. So I agree with you. Probably we can try to optimize the heart failure, try to reduce the pain score, and minimize the risk. And I think while he's transplant waiting list, perhaps they can try to ablate this because DT ablation success rate probably going to be higher than dilated cardiomyopathy. So I think I fully agree that if you can get the MRI, if possible, I don't know, CRTD device is compatible or not. So I think we can optimize the ICD timing, look at the QRS complex, optimize the heart failure, get the substrate evaluation of the MRI or if possible. Then maybe try to ablate. And that may be something that you rather put an amiodarone. That one option. But the other hand, if it's a mixed cardiomyopathy, outcomes are not going to be good. Very long procedure, patient likely getting complication. So that would be against that. So I think it's going to need a little bit of clinical judgment here. But I think that
There was the recent study, it's a sub-study of Vanish 2. They compared their amiodarone arm and they compared with VT ablation versus amiodarone. And actually, the arrhythmic death rate is same. No difference in VT ablation versus amiodarone. But the amiodarone arm shows a higher long-term complication and increase the non-cardiac death. So amiodarone toxicity may aggravate the prognosis of this kind of patient. But there's no evidence the VT ablation in heart failure improved the mortality of this kind of sick patient, except for Partita trial. So we need to be careful to make decision. But I think based on the Vanish 2 criteria, VT ablation is a reasonable decision. But if this patient really has the hemodynamic stress and the very severe heart failure condition, amiodarone is also still one of the options. So I'm not comfortable because the sinus heart rate is also very fast in this patient.
But since the patient has had multiple ICD discharges and some of the VTs were in the VT monitoring zone, if we give more antiarrhythmics, it will again further slow the VT, and the VT will be ongoing. So I think in this scenario, ablation will definitely help in order to, if not reduce mortality, but it will certainly reduce ICD discharges, and also not take care of the VT, because antiarrhythmics are going to slow down the VT and they will be always in the VT monitoring zone, but patient will be in persistent VT.
Dr. Bao, let me throw a last question now.
Sure. Yes, sir.
Quinidine would play a role on this?
Quinidine.
Yes.
I would not. There's a report. Quinidine or adding the flecainide is effective, but those are not the randomized trial, just a retrospective study from Stevens' lab. So
Well,
you can consider, but I would not. Yeah.
You know, Sammy Biskin published a paper years ago, as you know. Patient come with ischemic VT storm, VF storm. They quinidine can be temporized until you stabilize the heart failure. And then you can take to the lab ablate because the quinidine is a very short-acting drug. Amiodarone is a very long-acting drug, so you might aspirate it. Issue is that I think this patient needs a stabilization. Eventually, he need to go to transplant because he's 62 years old. So we all know that. So issue going to be what is decide the ultimate goal of this patient that will matter which one you're going to do now, ablation versus amiodarone and so on. So if you shall continue you plan to be ablation, you can put in quinidine and just temporarily suppress it. If you continue recurrent VT, then you can try. Especially in view that your VT, this patient is slightly irregular. It's not very monomorphic. That really troubles me a little bit. So maybe temporize with the quinidine, then you can take to the lab ablation. Okay, that other alternative issue.
Based on the ECG, it may not be the reentrant mechanism.
Yes,
and
that's
those
I'm worried right now.
has a poor outcome after VT ablation.
Right, that's why I worry with these points. But anyway, they will figure that out probably next few days. Okay, great case. We are over time now. Let's go to the EGM conference, gentlemen.
Thank you.
About the EGM conference. Taking 42 years old female, she has palpitation 3 years ago. Recently, it was reported 1 year ago. She has no other past medical history, and on echocardiography, the LV ejection fraction was normal. This is the baseline ECG, and it was a normal sinus rhythm, and heart rate about 80, and the PR interval QRS axis and the QT interval was within the normal range. The necklace was normal too. She has the symptoms of palpitation. She visited the ER, and there was a documented ECG. And on the ECG, it was the narrow QRS tachycardia, heart rate about 150, and the axis was normal, and there was no definite P wave preceding the QRS complex, and there was also ST depressions in the precordial lead. The chest X-ray was normal. So she admitted to our hospital to do the electrophysiology study for the diagnosis and the RF ablations for the SVT. The baseline catheter positions is like this. We was in the initial sinus rhythm, the cycle length was 80-15 millisecond and AH interval was 56 milliseconds. And HV interval was the 37 milliseconds and QRS duration was 73 milliseconds. During the RVP, rapid ventricular pacing 600 milliseconds, the earliest retrograde atrial activation was seen in the HIS 1 and 2. And during the single ventricular extra stimulus 600 and 안 보겠어. 600 and 320 milliseconds, there was a VA decremental perspective. During the single atrial extra stimulus test 600 and 410 milliseconds, there was the AH jump. And also there was the AH jump with single echo beat seen in the single atrial extra stimulus test 600 and 380 milliseconds. So the tachycardia was induced during this SA single atrial extra stimulus test. The cycle length was 448 milliseconds and AH interval was 383 milliseconds. And HV interval was 38 milliseconds and VA interval was 30 milliseconds and QRS duration was 76 milliseconds. This is the surface ECG during the tachycardia. The heart rate was about 150 and this is narrow QRS tachycardia. The axis was normal and maybe the retrograde P wave was fusion at the end of the QRS and then makes the pseudo S wave in the inferior lead comparing with the baseline ECG. So during the tachycardia, the HIS refractory ventricular extra stimulus was given, but there was no V reset. And during the ventricular overdriving pacing, post-pacing interval minus tachycardia cyclings was on 150 milliseconds. So in summary, the earliest atrial activation was at the HIS 1 and 2 in rapid ventricular pacing. The tachycardia was induced. Tachycardia induction was observed with the single atrial extra stimulus test with an AH jump. And AH interval was 383 milliseconds and HA interval was 68 milliseconds and VA interval was 30 milliseconds. There was no V reset during the ventricular extra stimulus test and PPI minus TCL was 150 milliseconds during the ventricular overdriving pacings. So the impression was the typical AVNRT. The ablation catheter positioning like this. So we confirmed the slow pathway potentials. And during the ablation, there was a junction beats, the junction region. After the RFCA, we did the rapid atrial pacing and the single atrial extra stimulus test, but the SVT was not induced. This is the post-RFCA ECG. So, thank you for your attention.
Nice presentation, Dr. Chen. This is your first presentation in Severance Hospital. Am I right?
Yes.
Okay. Thank you. And don't be too nervous. Your boss, Dr. Kim Min, is watching you online. Okay, Dr. Huang, please.
Well, I have nothing to say. She presented the perfect. She made the diagnosis and she treated it. Now, so you really can see any blip in the surface ECG now after your case? You think QRS complex, the lead 2 Is it not a little different than your sinus rhythm? Especially lead one, you can see some downstroke notching also. Very right after the QRS complex. A small blip there. In just beginning of S segment. Okay?
Yeah.
Yeah, that's short RP tachycardia. Okay?
Yeah.
So R2P, retrograde P is very short. So this is suggestive AV NRT. A little bit longer would be AVRT suggestion, but obviously non-diagnostic. So you can always put a differential diagnosis first, this, second on this, and so on. Okay? We are trying to make you guys think, open your mind, make a differential diagnosis. EKG, never diagnostic. Suggestion. So you need to make a differential diagnosis, okay? Next one. Next slide. Let's go take a look at that. Your ECG, I think. Okay. Now, is AVNRT patient, I did not hear, maybe I missed it. Is the body weight height matters for your teaching standpoint of view? Does that matter? Why I'm asking this question? Go back to your history. When you presented the case, your initial history, yes. So you said everything normal. Now, question is how tall, how much is this lady weight? Would be also important in matter. No, I'm not just trying to tell you, criticize you. No. If you're
Sorry,
thinking of,
Professor Hong, we can hear your voice.
can you hear now? Oh no.
저는 들립니다.
잘 들려요?
네, 저는 선생님 말씀 들립니다.
예, 다른 데는 잘 들린다 그러는데. Can you hear me? No? I think your microphone.
Professor Hong, do you hear
Yes.
me? Can you hear me?
I can hear you. You are not hearing me.
But we can hear your voice.
Well, maybe your speaker is wrong. Can you hear me or no?
야마하루데. 하드인.
I can hear you guys.
Now we can hear you.
Okay, good. So when you're considering your ablation, any patient, you should know body weight and the height. That body weight is, especially when heavy, your impedance to the ablation is going to be a little bit higher. Then you may consider put a 2 patch of a ground patch to improve your ablation efficacy. That matters. Second, height matters because especially AV node oriented tachycardia. Because if a patient is short and heavy, your heart going to be lying down. Then your tricuspid annulus will be tilted. Your space between slow pathway to the his bundle or AV node matter going to be very close. They increase the risk. The other hand, patient is tall, slender, your tricuspid annulus is going to be more vertical. Therefore, your node to the slow pathway is going to be longer, safer. Okay? So that is important. All right. Let's go to keep going down the other issues. Let's go down. About the is normal. That's beautiful. You've done really well. Let's go. Okay, look at the chest X-ray now. Go back to chest X-ray, please. Okay, so this is a nice, not that heavy lady looking at the chest X-ray, right? What do you think about this heart? It's a very slender, pendulous heart, right? So then this patient would be that one that has sort of more vertical tricuspid annulus. Okay. And then your coring sinus is going to be a little bit higher setting. Okay, let's go. What do you think about this catheter placement? No, go back, slide. This catheter placement, are you happy with this? You have a duodeca catheter, your his bundle nicely placed. How about the IV catheter? We talk about this all the time. Where this catheter you think is located? In mid-septum. Probably pretty close to the moderate band, I bet. Go look at the ECG now, intracardia. What do you think about this RV distal, RV12 EGM? Which is different than your RV34. Why so sharp stroke, downstroke? And then timing, if you draw the timing of your RV, EGM versus septal V, what do you think? It is really fast, okay? You should have a little bit longer delay. That means this is catheter that I always tell our fellows, don't put an RV catheter in the septum when you're doing SBT cases, okay? Especially when you're dealing with a left side pathway, things like that. Because it's created fusion, so your EGM cannot be analyzed properly. Sinus versus nodal conduction versus pathway, for example, basically you're pacing RV right bundle. In this case, probably won't matter too much, but still, I think if you want a differential diagnosis, probably not to put up. I would suggest you look at the article written by Dr. Melvin Scheinman, talk about the RV catheter positioning for differential diagnosis among the SBT. Okay, there's a paper written for that. If you don't find it, let me know. I'll give you a paper. All right, let's go down. Okay, so you've shown that diagram. Keep going down. Yeah, take a look at this slide. Okay, so this slide, they show you VA decremental conduction last bit, correct? Right. So can you say this is a nodal conduction, or you can say VA decremental conduction? Which one is it? In other words, VA decremental can be because you got septal axillary pathway can decrement, would be decremental, concentric, or you could be a nodal conduction, right? So how do we differentiate two? Only time you can differentiate when you see retrograde His bundle potential, that is a guarantee that's going to go through the AV node, which you have right there. You draw the line there. Can you see his distal 1, 2? There's a small tiny blip before your retrograde A, right? Can you see it? That time, yeah, that's the His bundle, retrograde His. So this is a clear-cut AV nodal retrograde conduction. Therefore, there's no axillary pathway. Okay? So when you present a case to the other people, you can say clearly, this is retrograde His bundle potential likely. Therefore, there's no axillary pathway. Okay? Then that's really nailed your diagnosis. Okay? Now let me go back to tachycardia now. You induce a tachycardia, and which aid earlier here? Which is atrial retrograde aid earlier here in your EGM? Can you see? CS 7, 8, right? Can you see CS 7, 8, 8? That's the earliest retrograde. That's expected, right? Am I right? So that would be retrograde earliest A, exit site, which probably close to CS also, I think, you're looking at the fluoro. So observing this retrograde A during AV NRT is important. Some patients, you're going to be inside the CS. That may be involved with the mechanism of tachycardia. That also can suggest you tachycardia target site you're going to ablate. Okay? Now you go to the ablation signal. So you had ablation signal here. Which one is the slow pathway here? Is there any slow pathway potential here? And the EGM ablation distal. The second one? Okay. So then why is it so far field? That's not a near field, that's far field signal. What's the reason that you're not recording near field signal there? Is it a catheter contact issue? Could it be one of them? Okay. Second one is that the tissue under the endocardium is not endocardium, maybe deeper into the septum, far away from your catheter, so you will not record sharp potential. And you can only prove that you're doing case yourself. None of us can tell you what is this. So in this point, what you could have done, rotate a catheter posterior clockwise, not pulling out, clock, harder rotation, trying to make a contact. See whether that second potential you pointed out, whether it gets increases sharpness. So then, in other words, become more near field signal. That would be better. Okay. Yeah. So I think that would be the only thing I have a comment here. But I think the case done perfectly well. I think it's beautiful AVNRT ablation. Okay. Yeah. And then last thing that for your comment, and then you had the junctional rhythm there. Take a look at the junctional rhythm during the ablation. It's this junctional rhythm. If you look at the first one and second one, third one, they are same or not?
Different.
They're the same? Look at the CS activation before you answer. They all same?
Slightly
Different. Different. Why is that? This is different than your AVNRT rhythm, right? Agree with me? Especially look at your last two. Yes. Why is it varying? Is the activation sequence matters? Yes, it matters. Why? This is automaticity rhythm. That's why exercise is varying because you're hitting. Now your activation is exactly the same as AVNRT. You're triggering AVNRT by burning it. That's triggering, so you're not in the right spot. Okay? So this type of keen observation is very important. And this point, I would have done pace HRA to make sure that you have a one-to-one AV node anti-gate conduction. Okay? That's the safety of because you don't know whether this junction rhythm coming from. Could it come from the compact node, right? With the different exit, which potentially you can risk a heart block. So at this point, as soon as you see a couple of junction rhythms, you want to stop, pace a higher rate, the junction rate, and make sure there's one-to-one AV node conduction, you continue ablation. That's the safest thing you're supposed to be doing. Okay? Otherwise, done well. Good. I have no other comment. Thank you. Wonderful case. Dr. Pao, hand it to you.
Yes, Dr. Huang, thank you. And I heard Dr. Hiteyu's voice. So do you have any comments?
I have nothing to do. It's so difficult. And I just want to say one more thing. And when you are presenting the ablation, before ablation signal, it's better to capture the higher speed with the well delineated local and far field potential of the ablation distal catheter. So yeah, that's all.
Okay, Dr. Taehyung Kim. And any other faculty?
Nothing to add. Yeah, I don't have any comments.
Thank
I
you.
have, oh, okay, please. Taehyung Kim?
I said thank you. Wonderful case.
I have critical comments, Dr. Che. In which EP lab did you do this procedure? You don't know?
6, 7.
Room 7?
I don't know which room.
Yeah, next slide, please. I don't allow this kind of noisy signal during RF ablation. Next slide, please. Yeah, what a shame. It isn't academic centers, the electron. So did you tell the technicians to fix it, Dr. Che? Dr. Che?
No.
Hello?
I didn't tell the technicians about this problem.
Yeah, so take care of and managing the one patient is very important for us, but you need to take care of your team. So make team more efficient and more careful. But this kind of technical problem should be solved immediately. So please tell them and fix it. It's room 7, right?
I'm not sure what exactly room.
I guess. And please fix it before I coming back to Korea.
Okay.
Critical issue.
Since you guys talking about the EGM, can I suggest one more thing for you?
Yes.
Please display unipolar 1, 2 when you ablate. Okay?
Okay.
Reason is when you deliver burn, you want to see current injury coming up, your local potential reductions, so on. So there's many benefit of displaying unipolar 1, 2 every single patient in ablation. Okay? Whether VT, SVT does not matter. Because you want to see your energy being effectively creating lesion, right? That's what you're doing for burning. So that would be a additional confirmation. Okay? And unipolar EGM sometimes very important to prevent the complication like a steam pop and things like that also. So that's probably something that you can add on. Okay? Great. Okay.
Thank you very much. Nice presentation. I'm happy to see my friends, Dr. Kyo, Nila, and the foreign colleagues. And Dr. Yu, can you tell us the teaching plan in March to May?
Sorry, teaching plan?
Yes. Usually we have we prepare the staff lecture and the EGM review for the new fellows, right?
Yeah, we allocated every like from Monday to Friday after the procedure. Each step will review that day's EP cases. Yet I have no plan with the lecture, so let's discuss it.
Yes, please. Yeah. Traditionally, we prepare the staff lecture, essential part, and for the new fellows.
Okay.
Okay, so in the Cambodia, we see very interesting case, and I tell you after coming back, and thank you very much, and thank you also thank you very much for your wonderful comments, Dr. Wang, and have a nice weekend.
All right. Everybody good. Have a good day. Take care of yourself. Okay.
Thank you.
Thank you. Bye-bye.
Bye-bye.
스탑 레코딩 영상이 원하시는 제한 인계창 되가 많다.